Imagine being admitted to the hospital with a life-threatening infection, only to have your healthcare denied months later because of a missing lab value. We've seen it happen too often.
In today's episode of the Outer Network podcast, we share real stories from the front lines of medicine, where doctors are forced to fight not just disease, but bureaucracy, and where patients are the ones who truly suffer. Let's talk about what's really going on and what we can do about it. Good morning, Dr. Seth. How are you?
Awesome. I do fantastic.
I would like to really talk about an important topic, which I think a lot of our listeners are really interested in. And obviously, we have spent a lot of time talking about really this broken healthcare system. And I guess, what does that mean? So today's episode, I really want to take a deep dive into insurance bureaucracy, the hurdles as physicians that we have to jump through with billing, and really who's the ones that are suffering. I want to talk about burnout amongst our colleagues, and the really important topic in America is this idea of defensive medicine, what that means, and potentially what the future of that looks like. I want to take a deep dive into inequities, inefficiencies, and how the system really prioritizes profits over people. So let's really pull back the curtain today on these problems in U.S. healthcare. And to start with, as a hospitalist, tell me your experience, good or bad, with billing, insurance, the hassles of insurances with patients in a hospital setting, inpatient.
Awesome. I think, and I'm super excited that we're talking about this topic. I think when you and I had talked about these kind of podcasts, I think this was the topics that got us excited. Right. And I also acknowledge that I think majority of the people who potentially will tune into this or other programs, healthcare minded, are really looking for the nuts and bolts of how the system works and what potential solutions, right? And so I think the biggest thing that we need to talk about is like some of the biggest expenses, and insurance is a big expense. Hospitals are a very, very large expense. Having the opportunity to work in a hospital for the past 15 years and being part of insurance administration in the hospital side, I've had a unique understanding of it. I also see there's two sides to a story. You know, you can't run a hospital if there's no financial aid or an intake. And it needs money to run. It has doors to open, electricity, staff to pay.
Right.
We understand that.
And healthcare is expensive.
And healthcare is very expensive. On the flip side, the insurance companies are also, they have a job to do. They have to pay for services that they've been paid for. And that makes this thing very difficult. The difficult problem in this is, like, you got hospitals on one side, you got insurance companies on the other side, and then that patient is lost in the middle. So I think one of the things that I used to struggle with seeing insurance payments was the amount of denials that hospitals get. Mm-hmm. And they didn't deny it based on the patient's desire to be in the hospital. They denied it based on questioning the medical diagnosis, right? So
these are patients already in the hospital,
right?
Or patients referred from an outpatient primary care physician.
So these are patients who are currently admitted in the hospital for whatever reason. Let's say they are admitted for sepsis, okay? And our hospital doctor takes care of them, admits them in the hospital for a condition called sepsis. Sepsis is a condition where
it's life-threatening.
It's life-threatening. It is a condition where there's an overwhelming infection. That infection is so severe that the body's response is to fight it, and then unfortunately sometimes the infection can take over, blood pressures can drop, Patients can get sicker. They can potentially be in the intensive care unit. They can be on life support. It can get serious.
So in other words, you cannot manage sepsis for a patient outpatient.
Absolutely not. Sepsis cannot be managed in the outpatient setting. It is a critical issue. So what oftentimes patients happen is they come to the emergency room. They'll be febrile. They'll have low blood pressures or something like that. They may be even confused. The form of the infection is found, and then they'll get admitted. The doctors will diagnose, I'm taking care of sepsis, I'm giving them this antibiotic, I'm giving them this fluids. And then 3 months later, the insurance company will be like, well, we don't agree with your sepsis diagnosis because this lab was not tested or this lab was not abnormal. And in our calculation, it doesn't technically meet the criteria. And so we're just going to give you this diagnosis worth of money. And the insurance and the hospital company is like, this is the part where the physicians are not involved in this, right? So the physicians have been already taking care of the patient. The patient's left the hospital, taken care of. The bill has gone to the insurance company, and the insurance company on the first go around says, yeah, we don't agree. And so now the hospital has to hire a team of nurses, a team of doctors to take in all this information, write denial rebuttals, letters. It's time. It takes a capital. And then we have to respond and say, we disagree with your assessment. This is based on this reason. We think you should honor this diagnosis. And then they'll often come back and say, well, maybe or maybe not. And honestly, half the time, they just don't agree with it and they don't pay it.
And this is one insurance company's guidelines that you're just expected to know.
Well, you're 100. So the insurance companies may not necessarily specifically have a set of guidelines because their guidelines internally change, right? So, man, we don't know. Today, they picked sepsis as the diagnosis that they feel is costing them too much money, and they don't want to pay as much.
And Dr. Seth, how are you as the physician taking care of this patient? How do you know when these guidelines change?
We have no idea. And because I'm on the administrative side, I see our coding team will say, it seems like they're denying a lot more sepsis this week, so just be aware.
And make sure you order potentially unnecessary tests just to follow.
That's a great point. So patients who come in with respiratory failure, that is a new thing that I just found out this last year, that some insurance companies were saying that acute respiratory failure was not diagnosed appropriately. They'll often deny. And they'll deny it for a number of reasons. Imagine this patient came, I was reading a case where a patient came to the ER, was on 4 liters of oxygen, was visibly distressed in the comments, was given nebulization, still required 2 liters of oxygen, had to be admitted to the hospital. Started on antibiotics, was diagnosed with a pneumonia. Very reasonable condition, clearly was an acute respiratory failure. The denial was, you didn't check an arterial blood gas. And you didn't, in the physical exam of the emergency room doctor, he wrote not in distress. So we disagree with you. And they held up the diagnosis. Now, what does that mean to the hospital? That means that hospital that spent quite a bit of money taking care of that patient
and saving this patient's life
now is being paid a fraction of what they actually paid to take care of that patient. So what the reality is now the consequence of that is the hospital still has to make their money up somewhere elsewhere. So the next guy who comes in, unfortunately, gets offset some of the pricing. That's where that whole conversation of like, oh, this hospital charged me $35 for a Tylenol. I mean, I don't know actually if that actually happens, but that could explain some of the reasoning of how some of the pricing gets offset.
Well, and then that next patient that comes in with sepsis, who has a different insurance company, has potentially other different metrics that you as the admitting physician have to meet. And chances are that they will deny their stay as well.
And so now
the cycle continues.
Yeah. And now So what ends up happening is the coding team will call the hospital doctors and say, hey guys, we're getting denied on a lot of these sepsis things. We need you to do this, 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 this. And some of them seem to be fairly arbitrary. Like there was this one case where we got denied a case where the patient did not get the appropriate fluid bolus per the guidelines of the insurance company. So imagine like the insurance company is dictating the terms of the treatment. Now, I'm often saying like, well, that patient had a history of congestive heart failure. That patient had an ejection fraction of 35%. For people who are listening to this, that tells me that they have a weak heart. You can't bolus them 3,500 milliliters of fluid because it would potentially cause them to go into pulmonary edema or in heart failure.
And is there any representative from an insurance company at the bedside that's seeing this patient, identifying what you are doing or may not be doing? You are the one taking care of the patient.
Yeah, never, obviously. The insurance companies, so this is what always has frustrated me. The first set of denials that come out on those first pages, the sepsis denial, most of the time it's not even denied by a physician reviewing the case. It's reviewed by clerical staff, nursing staff who review the chart. They're given their guidelines, this checklist. Oh, it didn't meet the checklist, denied. Then again, this comes to our coding department. They bring it to our team that they've hired to fight all this. Again, these are the things that raise healthcare costs, right? Because they got to hire staff to fight this. And then the staff then makes these letters, argues with them. Then they will, most of the time, deny it again.
Yeah.
Then the physician and their physician have a peer-to-peer conversation. And many times the insurance companies will say, oh, yeah, it seems pretty reasonable. I mean, my goodness. Look at the amount of expenses we have made to just get to the point where it was.
Right. What's sad and frustrating is, as the physician, how much we are in the middle, because a lot of patients don't always understand their insurance contract and what the language of that contract states when they purchase a policy. And when situations like this happen, we are in the middle. We are obviously, we've taken an oath to first do no harm and protect this patient and take care of this patient. But also, these patients are throwing slings and arrows at us for not doing better, or why, for some reason, it's our fault that the insurance company is denying this.
Yeah.
So we are constantly in this battle of being in the middle.
Yeah. So tell me, in your experience as a primary outpatient physician, what has been your experience with, being caught in the middle and your dealings with insurance?
Yeah, it's interesting. I feel in the last 5 years, more and more of the tests or procedures that I want done for patients are denied. It never used to be so difficult. I had to get authorization from an insurance company the other day for Zofran, which is an anti-nausea medication. And I thought, has it really came to this? Are these insurance companies really trying to control the cost? I don't know the reason for that, but
and to explain to people, Zofran is the most commonly used prescription-based anti-nausea medication, and it's pennies on the dollar.
Correct. So why would an insurance company want to deny that? So in my experience, it has been much more challenging to get things approved. And I'm going to talk about my experience living in Las Vegas, where we know that this is the one state of the nation that has the lowest reimbursement than any other state of the nation. I think from a business perspective, if you are a traditional physician working in Las Vegas, Nevada, and your primary source of income was insurance companies, going back to what we've talked about before, it is all based on volume and not quality. And if insurance companies are not reimbursing you as what they say did 5-10 years ago, you're going to have to physically see 50 or 60 people just to keep the lights on.
So if I could summarize what you're saying, the insurance companies are not paying the primary doctors their worth, what they're paying, they're actually what they're worth and what their value is. Therefore, in order for them to run a business at all, they have to see large amounts of patients, and that equates to less care, less quality.
Correct. And it's all depending on the contract that you have with these insurance companies. So, as I said, as a concierge physician, I have to charge a membership if I want to deliver the care that I want to for patients. I cannot rely solely on insurance reimbursement, right? I would not be in business anymore. In the outpatient setting, for any medical office visit or procedure, there is a certain code, certainly depending on the time, the intricacy of that visit, the challenges of that visit, you designate a certain code for that patient. That gets thrown off to the insurance company, and then magically I get some type of reimbursement. It's interesting that certain insurance companies will pay me differently based on that same diagnosis code.
Really? So like a urinary tract infection, for example, that you treat, and
let's say you come in for a UTI,
right?
And you have urinary urgency and frequency and burning. And I may do a rapid urine analysis in the office, confirm that it is a UTI. Sure. I may check your blood pressure at the time. If it's high, I may treat that. I write all that in a detailed note. I'll probably label that as a level 3 visit.
Right.
And turf it to the insurance company. If you were a Blue Cross Blue Shield patient, which my contract with Blue Cross Blue Shield, take a guess what they would pay me. And this would probably be a 20-minute visit.
Like a 20-minute visit, like a couple $150, $120?
$23.
So they value
my contract with Blue Cross Blue Shield. So they are paying me $23 to see that patient. If I was only seeing Blue Cross Blue Shield patients in Nevada, if I saw 10 patients a day, do the math.
So I remember you got to pay your building, turn on the lights, pay your staff.
Correct.
All the overhead.
My malpractice.
Yes.
The taxes, the overhead expenses, the medications, the utilities. I mean, it is staggering.
It's almost like insurance companies have created a system so that we don't use them, right? And I think that's what DPC is the consequence of, Physicians just said, I'm
tired of this.
They won't take insurance.
I don't want to deal with this anymore. Almost flip the insurance companies off and say, I'm just going to charge a flat cash fee, and not even deal with insurance. As I said earlier in one of our previous episodes, as much as I dislike insurance companies for what they do, I still think as a physician we're entitled to that.
Yeah.
We are still providing a service, and I still should bill.
And honestly, the patient is paid their service. The patient's paid for the cheeseburger. They deserve that cheeseburger.
Correct.
Right.
Correct. So it is a challenge. And I don't know if a lot of our listeners even understand when I order imaging, an MRI, for example, say you come in and I'm concerned about your chronic low back pain. You've done the physical therapy. And I think at this point we need to do some imaging. And we order, my recommendation is to order an MRI of the lumbar spine. I have to jump through hoops to get that approved. So it's not as I write the order, my medical assistant sends a referral to the imaging center and the patient can go there the same day. We may have to wait several weeks before that MRI is actually approved. So I have to rely on someone on the insurance company's end to review my note, and I'm at their mercy whether or not they're going to approve that. And I've kind of learned a little trick. And a lot of times if they are denied, you can absolutely call for an appeal.
Yeah.
And 99% of the time, I'm speaking to a nurse or someone who is making decisions. Very rarely do I get to speak to a physician. And so I have learned that when I speak to this person, I'm very quick to pause, and I ask them they ask me a certain set of questions. Who are you? What are your credentials? This is the patient that we're going to be talking about today. And I'll say, that is correct. Before I begin explaining you this clinical data, you need to know something. I'm their physician, and I need to ask you, what are your credentials?
Right.
What is your state licensure?
Yeah.
Are you board certified?
Yeah.
Because I would like to make sure that you are part of this decision making.
Yeah.
Because at the end of the day, we're stuck in the middle. Yeah. If I can't get this approved, I can't take care of this patient.
Yeah.
And their stuff.
So my buddy is an oncologist, and he would tell me that when he had to deal with insurance claims and denials on treatment, like chemos and stuff like that, he's not calling them because he thinks his treatment may not work. Like, this is the reason why, right? And so if he ever got a denial, he would ask them, can I just get your name and physician ID number, MPI number? I just need to put this in the chart because you're denying it.
Right.
And if you're going to be part of this medical decision.
And they're very quick to approve it.
Yeah. Yeah. So, and I don't know if that's a trick or nothing, but like, if this might save some time, then go for it.
I'm giving away my secret now.
Yeah, that's right.
So why, in your opinion, Dr. Seth, is this such a challenge?
Regarding, you're talking about like insurance approvals and whatnot?
Correct.
I mean, it's economics. Let's be honest. An insurance company has to make profit. They have shareholders. A hospital corporation needs to make profit, although they are 90% of them are non-profits. And that we can talk about that all day long. And their goal is to grow their institution, to pay their physicians, nurses to take good care of them. There's that balance.
Right.
At the end of the day, it's dollars, right? The problem is our patient with the MRI, our patients who are waiting for the chemotherapy, they're the ones who are lost in the battle, right? Right. So, and it's, as long as we can educate our patients about how to take back their system, it's a reasonable thing. And I think that's where.
Do you think it will get better, or do you think it's going to get worse?
I don't. I think things like concierge are the answer to the problem, but I don't believe there is a systemic change that is on the horizon.
Let's talk about that a little bit more detail. So, if concierge medicine is the answer, what do you think is realistic in the future for cost savings? Obviously, I think there is a need for insurance.
That's all right.
Obviously. But what do you think needs to happen?
So, I think there's going to be a lot of ways to address this. Let's look at what happened in 2008. Okay. At the time of between 2004 and 2008, we were having the Iraq War, right? And I was in my 20s, and we were at the same. You and I remember like the society stressors at that time.
Mm-hmm.
It was the housing boom at that time, the credit cards that were like exploding, the Iraq War, and the conversation about healthcare. And the conversation about healthcare at that time was denials of pre-existing healthcare conditions. That was like the common discussion. And so after the economic collapse in 2008, 2009, and when, an usher change in with, political change, and the conversation changed from the housing boom to like healthcare, right? And the decision was, we got to fix healthcare. And that was a great discussion. And it was a very, very lively conversation. People may argue about their opinions on what happened with the Affordable Care Act, but we can say a couple facts. Fact one was everybody, I shouldn't say everybody, more people got insurance, right? More people got access to care. That we can say.
Which you think would drive down the cost.
You'd think so, right? The thought was that, hey, everybody's gotten access to it. It should drive down the costs. And then, there were some guidelines from CMS that was recommended to all these hospital systems to reduce hospitalizations, to improve care. And they also were there to improve costs. Now, we can deduce and go through the details so much, and we can argue about that. But there are two facts that happen. Healthcare costs exploded, and hospital systems got bigger, and that was it. Hospital systems knew we got a payer, a guaranteed payer. There's way more patients coming in. I don't know if you guys ever worked in the hospitals during that time. All we saw was record census every single day in the hospital. Oh my gosh, we hit a record census because more patients have. Now, that is a consequence to the situation. Sure, people were sick. People needed insurance. This wasn't there before.
I have the availability. I can use it now.
Yeah, and like
have access to.
Yeah, and so what hospital systems is, they gobbled up this clinic, gobbled up this little hospital, and they got bigger and bigger. So the small private doctor, that guy was gone, right? You don't see that very often. Right. Whereas in the 2000s, that was what you saw on the street, right? And now because the insurance companies are now bigger, because they got all these mandated patients to make sure that they are having to get insurance, well, they get to dictate their policy, right? So this, now, I'm not saying that there wasn't good intentions with this, and I have no desire to get into a political discussion about it. But there is ways that we can address this. And I think finding a middle ground between finding like a private auction is a solution, right? We do have to take there are some patients that don't want to be a part of the big systems, that would like to get out of that. And we also have to say to the government aspect where you can't always guarantee these big companies they're going to get a lot of money, right? Insurance companies just looked at the side of the insurance of the government and said, if you're going to guarantee me 30 new million patients, I get to do a lot of crazy stuff now,
Right. My take on this is, I look at the fact that 90% of healthcare expenditure happens in a primary care setting. And wouldn't it be ideal to have a plan that really focuses on really good primary care, preventative care, but also have the ability just to use insurance for catastrophic situations? But most of those, where most of those premiums are going towards a primary care setting. And face it, how often do we really I'm a young, healthy individual. I don't go to the hospital. But you never know what that unexpected may look like. You and I may need it. Why can't we have more insurance plans that just focus on catastrophic situations, and then let's all the kind of more funneling of funds into a primary care setting?
Yeah, and that would be an ideal situation in certain cases. I think in some cases that is currently how some insurances are. They offset that with low cost, high deductible.
Yeah.
Right? So those are the ones that they say, well, we are covering you for hospitalization. You're paying a smaller amount of fee and we have a high deductible. Well, here's the crux of the problem. That low fee just tripled, quadrupled, even more so in the past 10 years. But that originally, that was a good idea. High deductible, low cost.
And I see that all the time.
Yeah, but now the patients are paying their entire salaries and mortgage and this and health insurance, and all of a sudden they still have an $8,000 deductible, which is why like they're frustrated. And I don't blame them.
And which is why I think what I mentioned in one of the other previous episodes, why patients in a concierge setting may actually pay less out of pocket in situations where those patients that do have high deductibles, if they don't want to use their insurance for an MRI and they want to pay cash, it is quite affordable.
Yeah.
Labs are quite affordable. And I encourage patients who are even not in my panel to always talk to their providers about cash options, because I think it will save you a lot of money.
Like we were talking about that. We were shocked when we found out that the hospital system that we are working with, that a CT scan was a fraction of the price. Right, we paid cash, right? And I was like, but is this a negotiation? Is this like a special deal that I'm getting? They're like, no, we publish this on our website, right? And I was like, then why is it so expensive to insurance? Because that's the game.
Yeah.
And I don't know the response behind them.
And why is it inflated so much?
And I honestly don't know the answer to that, because you can talk to the insurance companies and you can talk to the hospitals and they'll say, well, it's offsetting certain costs and this and that. But like, why is that the responsibility of the patient to deal with your costs?
Yeah.
Right? If it is, let's call it what it is and let's just do everybody this pricing. Right. But, I don't know.
Coming from Canada and now living in the United States, I'm going to ask you a really challenging question.
Let's go.
How would you design a better healthcare system in this country? Knowing Canada's system, pluses and minuses there, the United States system, pluses and minuses, how would you design a better healthcare system here?
So I recognize the benefit of having a public system. And I remember, I'm sitting here in a suit talking about concierge medicine, right? I bet I see the benefit of it. I was hospitalized a bunch of times with asthma when I was a kid. If I was hospitalized and my parents didn't have insurance at the time, it would have bankrupted them and when we were kids. Now that doesn't happen in the U.S. Kids are all they're taken care of, and that's an amazing feature of the United States that nobody really talks about, right? But in Canada, if you need hospitalization or you are in the emergency room, the thought that you do not need to worry about the fees is a fantastic thing, sure, right? That also means that everybody with any sort of worries whatsoever lines up in the emergency room, right? And that also puts a huge stress on the system because there is no impotence to hold back, which I get, right? And that is a wonderful feeling that you do not need to worry. I remember this one time I was a kid and I was on a bicycle. I was learning how to ride a bike, and we were in a parking lot in the apartment that my dad had rented, and I was riding a bicycle behind my friend, and we were racing, and I slammed into a parked car, and I remember my arm hurt so much, and I couldn't move my wrist. And I'm crying, and I'm also like loving the attention. So, like every 8-year-old, like, oh my God. And my dad says, I think I had to take him to the hospital. And I was like, I'm going to get a cast. But, I was all like kind of excited.
Yeah.
And my mom took me to the hospital, which was across the street from where we lived. And so we sat in the ER. 3.5 hours later, my mom's like, how's your arm? And I'm like, I can move it a little. She's like, let's go back. Well, now the response is the critical naive response to this is like, well, oh, this is great. Your arm got better and you didn't need treatment. And the ER's purpose was there if you needed it there. And it kind of filtered out the issue. But the reality is that 3-hour wait was definitely going to be 10 hours. Like it would have been even longer. Right. And I've had other experiences where I've been in the emergency room. I'm tripoding, and tripoding is like positioning yourself, breathing in asthma, and they just keep doing the O2 monitor, and you're 91%, and they wouldn't give me Adderall. Yeah, and I'm like, I need some treatment, like I cannot breathe. So there's the consequences of that. physician, I have family who are physicians there. They actually do like the system because it's beneficial for them.
Do you think they're as burned out as physicians are in the United States? What you're hearing or reading about?
You know, my scope is very narrow with the people I talk to there. But you know, they have the ability to kind of dictate their own terms there.
Mm-hmm.
You know, they're actually, all the physicians there are not hired by the state. They're individually run corporations. So my cousin, for example, she's an individual corporation. So she dictates her own business. She works 4 days a week. You know, that's how she runs her practice. She has a very busy practice and she has a very good practice. And I think she's a phenomenal doctor. So the city of Winnipeg, where we're from, benefits a lot because she's there. But I also see some other people where I have a brother-in-law who's an orthopedic surgeon who gets frustrated that he can't give the amount of care to the amount of patients they have because he is a surgeon and you need operating room time. And they don't have enough operating room time in this town they're in. So, and that operating room time is limited based on the staff they have, the facilities they have. And he's like, I got 2 surgeries to do. And meanwhile, they have, you know, many, many people in line to get surgery.
And these surgery centers are built by the government.
I guess so. And that I'm not 100% sure of, but I believe they are. They're institutions that are built by the government. He's his own individual physician as a private individual coming and working in there. But, you know, there's not enough staff, or the staff are not on today, or I think their union may have some certain requirements about timing and stuff like that. So there's a lot of limitations to it. Mm-hmm. In Manitoba, for example, they had such a backlog of patients waiting for spine surgeries, like critical spine surgeries, patients who've been waiting for years, unable to move. They made a contract with the state with a hospital in the North Dakota system where they would bring their patients and get simple surgeries and be discharged after the next day out of the hospital. I would take care of those patients in those hospitals and they would be ecstatic. They'd be like, I haven't been able to move in years and now we're finally able to do this stuff. And they were so happy. And imagine this would have been a longer duration of waiting. And that is part of the problem with the public system, right? So flip side that to the private system where we have lots of access, but then we're dealing with the current system of like dealing with insurance companies and stuff. So if I was to say like an ideal system in the United States is that I wish we would have one purely public system, the universal system, and one purely private system. I know that sounds crazy.
So you have a system that is available for those people that need the care, and then in a system that if you could afford it, you can go more in the private sector and want better care.
And the public system we already have a universal system in the United States. It's called the VA. If you've ever worked at the VA or been at the VA have all the doctors they need. They have all the staff. They have controlled costs. They have their own electronic medical record system. There's some ups and downs with the VA, right? But the patients get their care. They get their medications. Our veterans are taken care of very well, but there's a wait, right? And that is a universal system, right? Okay. And anybody who says that there isn't a wait is a liar, right?
Yeah, I have several patients that are part of the VA,
right,
but also pay a little bit extra. And and I've actually spoken to internists in the VA, and we work very well together. And it's actually worked out pretty well in this situation for this couple.
And that's exactly where like you can have a system where there's a universal system and it provides access to the patients and it's paid for by whatever process is decided by society. And then you could provide a private system where, insurance and hospital systems, duke it out.
Right.
And I think that's where concierge medicine has kind of developed is like, we're kind of a response to this whole, we don't like this system and we don't like this system. We'd like to just make our own kind of system. Mm-hmm. And historically, what we've noticed is our success rate and our satisfaction rate from our patients is through the roof. It's much more than if you look at the hospital systems or the other system, the public systems.
Yeah. It's very interesting.
So let me ask you a question. So we're talking about costs in medicine, and we're talking about, the improving the care of patient care. But what we haven't talked about is defensive medicine and rushed care. What's your opinion on defensive medicine and the state of healthcare in the United States?
And I think for those that don't quite understand, defensive medicine is basically, as a physician, if you're seeing a patient and you know for 98% certainty that this is a UTI, but in the rare chance this may be A, B, C, D, you are taking the stance of ordering extra tests that may or may not be important. And I think in the United States, this idea of defensive medicine, we need to order more just to prevent potentially any lawsuits from happening. I would say I'm a very good physician. I got great training. I know how to take care of patients. And I think what's ideal in my situation is I have good quality relationships with patients and I know them intimately. And so for that piece, I'm not always on the defensive game. Now, for a patient that I may not have a relationship with working in the ER, yeah, you may catch me probably ordering some of those unnecessary. I don't want to say unnecessary, but other tests just to be on the safe side.
So if you are saying that this is the first time you're seeing this patient, they're coming in and in the emergency room setting, they're complaining of some sort of vague symptoms. You're based on your clinical acumen, based on the lab tests you've done, you figured out what the decision is.
I want 99% certain.
But just in case, I'm going to order this very expensive test like CT scans or MRIs just to be on the safe side.
Just to be on the safe side.
So what's really interesting about this is I think this is one of the major driving costs of the United States. And there's some data behind this as well, that defensive medicine has caused a massive increase in imaging and ER visits and hospital stays. Now, what the question is like,
and is it who's to blame for that? Is it the administration? Is it the fear of a lawyer? Is it the fear of lawsuits? What is really driving this?
A, B, C, D, all the above. The responsibility of ordering tests is always up to the physician. So I think the physicians do have a responsibility. It's very easy to just go in the room, leave the room, order a whack load of tests. You're all negative, go home. It's pretty crappy care. Let's be honest, right? And I'm going to be honest with you, my wife experienced that in the local ER just recently. My wife had, and we're going in a little bit of care, but she had, a little concern of something in the middle of the night. And I was worried, and there's nothing I can do. And as a physician and a husband, I like to wear my husband hat role a lot more. So I took my wife to the emergency room, and the physician came in for maybe 30 seconds, looked at her from this far away from a flashlight, ordered a whack load of tests, including a CT scan. Fortunately, everything was fine, and we ended up going home and the $5,000 EI bill, right? So did he even put his hands on her? Did he check? Did he look through her mouth? None of that stuff, right? That flashlight from across the room cost me $5,000. And I was annoyed at the guy, right?
I think it's important in medical school, we learn really the significance of that physical exam. And I even say having the ability to communicate and take a few minutes to really talk to the patient. Instead of being so quick to go in, ask a few questions, order all these tests just to confirm that, yes, there is a fracture there.
Yeah. The other people that are responsible for this defensive medicine is the hospital system. The hospitals have the incredible ability to tell and talk to the doctors and say, stop ordering so much unnecessary tests if you think it's unnecessary. There's no reason. Why? Because every scan brings them money. Yeah, it's not like they're doing this for free, right? And then, I've never met an administrator who will admit this. Sure, right? This will never happen. Though I plead the fifth. But in reality, it is not necessarily in their ball game to shut down the imaging center. Sure, right? But they may say, oh, we think you should focus on the guidelines, and you can manipulate that all you want, right? Okay, so the ERs are churning out images. The radiology department is booming with images, right? Unnecessary lab tests, etc. The legal system and the government system definitely has a responsibility as well, because in many states there's no tort reform, there's no limitation of lawsuits. Here we live in Tampa, and all we ever see is like billboards of like what legal teams have got lawsuits for, all sorts of injuries and whatever. It's like, like if physicians were worried, they see that billboard. I'm not necessarily blaming the patient. I actually think that patients, when they come to the emergency, I don't think that's their intention. Right? I actually think the physicians are just scared.
Yeah.
Right? And that's also, their lack of understanding of the system. Right? And then the last one is, sometimes a little bit of that responsibility falls on the patient.
Sure.
Because like the patients come in, they know what they want. They've Googled it. They've, chat GPT'd it. My cousin told me I should get a CAT scan. And that a physician is likely going to listen a lot to what the patient has desired. And if they don't, there's a consequence at the end side too.
I see this all the time in the outpatient world, where it's almost, you wonder who is talking to who and who's putting together these guidelines. And I feel sometimes you have to jump through so many hoops just to get what you want. So this patient is going to get charged this and this and this before you want to get to the test that's going to give you the answer. So all this expenditure is going out automatically at the discretion of what the insurance company is saying before you just want to jump straight to the test. That's the most frustrating part for me too.
So, do you think all this is really the number one reason why you hear about physicians being so burned out, hating their careers, suicide on the rise amongst our colleagues? Do you think this is really the biggest thing behind the burnout, is dealing with insurance companies and the burdens of that? Or is there something else?
I think there's a lot of things that go into the burnouts. When you work for a hospital system, a major focus on the burnout was the amount of days you worked in a row, the amount of hours, the shifts you did, and they've done a really good job making sure they limit those sort of problems. But, when you go home and you're taking home that stress of, I've had to battle so-and-so insurance company, or you're taking home, charts to work at home, that, you're not at the hospital working, but you're at home working. And then there is the aspect of, making sure you're doing a good job, right? And you want to have satisfaction at your job. Everybody wants to have some form of satisfaction at their job. That's part of why people love or don't love their jobs, right? And if you're getting rewarded, and every day, patients are happy and excited to see you, and they're getting the treatment that you are recommending and things, that is an ideal system. But that's not reality of how it works here. So I think there's a multiple factor aspect in the burnout issues in the United States with physicians, healthcare in general. I think nurses are interesting, and they have a huge amount of burnout. Yeah. It's funny because if you ever see a nurse, a newly grad nurse, nursing schools have expanded throughout the United States because of the demand. Nurses' jobs are exploding all over the United States, right? As healthcare grows, nursing staff have grown. But whenever you meet a nurse, they're a new nurse. What's your goal? their goal is to become an advanced practice practitioner, a nurse practitioner, and so on. So like their goal is an out.
Yeah.
Right. The thing is with physicians, there's no out. There's no like, I plan to sail sail around the world and like get away from all it. Is that there's no out. This is X.
Yeah.
Right. And that involves long hours, working nights, being away from home, missing a lot of important moments with your family. So those sort of things contribute to it.
Wearing the white coat is very heavy. And I can see it a lot in colleagues. And I know I'm in a little bubble, and I'm very blessed to be in this bubble, but I also am very sympathetic to physicians. I don't feel a lot of people know really truly the demands that are placed upon us. And it's quite sad. I know the majority of physicians care deeply about their patients and are doing their best. And unfortunately, we are really not set up for success in our current system.
Right.
So
tell me how you from the bubble that you describe here in there, tell me how you feel that the system, what's the system's priorities, people or profit?
yeah, I was 100% profit. And ultimately, like I said before, why is it so difficult to get things approved? Patients are paying more for their health insurance than they ever have, and they're getting less.
Yep.
So I think this is why I am very passionate, why we are very passionate about concierge medicine and really what that can provide for patients. And I keep saying this over and over and over again. It's having that relationship with your patients to really focus on spending more time focusing on preventative care and not be so reactive, and really working with the patient to come up with strategies to really optimize care.
Right. So what you're saying is that the system is geared towards profit, and the patients have to take healthcare in their own hands.
100%. Yes.
And I think that's a really unique thing, a perspective that people need to grasp, because I think
historically they have an advocate to help them along the way.
Yeah.
Where they are lost in the system,
right?
Who have no one who understands this healthcare landscape.
Yeah.
And they're on their own.
See, that's a really interesting point about the public system. The public system is you just go to the one door, open the door, and there's healthcare. The wait is there, but like that you navigate through the halls because somebody takes you through it.
Yeah.
Here you have insurances, urgent cares, ERs, standalone ERs, systems, hospital systems. There's so many things going on.
Yeah.
You can't blame the patients for not knowing. It's 18% of our GDP. It's a massive, massive, massive portion of our economy. And patients are like, we're just like, figure it out, guys.
Yeah.
So yeah, of course.
Our healthcare statistics are not that good.
Right.
For spending 2 times
yeah.
than any other country.
Right. So like, it is definitely geared towards profit. The response, as you suggested, is patients need to take control of it.
Absolutely. What are some other things that patients can do, or what can we do to help our patients navigate through this current system that we're in?
I have thought about this a ton. I was thinking of like trying to create an app or a software, and I think that's been done ad nauseum, right? And they all fail, right? Nothing works because the system is so complex. The system is complex and it changes constantly. It changes based on administrations, the government administration. It changes on today and the next day. It's too complex to navigate. You need somebody to hold you hand in hand. That's it. You need an advocate, right? You need a patient advocate. And when I do that for my patients, I feel like it's my job not only to help treat and diagnose the disease, but it's also to help them navigate the system.
Yeah. There's a lot of inequities and inefficiencies through the system. And I'm hopeful for the future. I'm also nervous about the future and what that looks like. Healthcare is very challenging. I think we also have a lot of other issues that we haven't even skimmed the surface on with with what's happening in our country with our health in general, the obesity epidemic, the pediatric obesity epidemic. I mean, we think healthcare is expensive now. What's it going to be like in the future when you have an entire country that is not healthy? We already don't have enough physicians. What does that look like? So I say I'm hopeful, but I'm also very, very nervous on what that looks like in the future. So, any other questions for me, Dr. Seth?
I think this is step one of like a multi-step investigation to like the healthcare system that I think you and I are going to get to have a chance to explore.
Yeah.
I think
the takeaway message today is I think physicians understand the situation. Sometimes we feel powerless to it, but I think the more and more individuals, patients, physicians that get excited about this topic, I can't help but think that that's going to promote some change in the future.
Yeah, I agree.
And that's why I'm hopeful.
Well, this concludes our episode of the Healthcare System for Auto Network podcast. Do us a favor, tune in, log in, sign up, like and subscribe, share it on your social media, shout it out from the rooftops. Thanks for joining us.
Thanks for watching.